very grateful to welcome you all here today. It's June 4th, 2026, and this is our monthly informational educational meeting of the Florida End-of-Life Doula Alliance. We formed our nonprofit 2 years ago, and we're just very happy to be here. We like to provide topics that are of interest, and this one is obviously very important to many people. And so the title of our talk today, of our meeting, is The Emergence of Death Doulas in the Medical System. And we all know that we could play a wonderful, important part in the medical system, but we're not there yet. We're there a little bit. So we're anticipating growing and becoming more known and wanted, and becoming an integral part of the teams, so that the medical folks can do their thing and have the non-medical folks there to support them. And there's a lot of ins and outs to it. So leading up to this meeting, we've had Jay and Bob and I have had a couple of good long meetings and shared some excitement. And our third speaker is going to be Nathan. How do you pronounce your last name, Nathan? I don't want to butcher it.
Vargovcik.
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 Vargovcik. Okay, thanks. And I will do your introduction after we have the first two speakers, so that we'll do it that way. So, Bob Russo, raise your hand, Bob, the guy on the right. He has an MA in pastoral counseling and psychology. He's a certified life coach and a certified death doula. Bob walks beside those nearing life's final chapter with tenderness, compassion, and when the moment calls for it, a gentle touch of humor. Because dignity, love, and even laughter still belong at the bedside. So Bob utilizes his skills as a life coach and translate them into end-of-life care, emphasizing what it truly means to live fully right to the end, and to hold space for both gravity and grace. So we're very happy to have you here, Bob. And Jay LIPPMAN, MD, he's board certified in internal medicine, board certified in hospice and palliative care medicine, and certified hospice medical director, now retired, right?
Yeah.
And
first.
Yeah. Dr. Jay LIPPMAN's a board, I said that. So he's got over 35 years of medical practice, and much of his career has been devoted to caring for people facing serious illness and the end of life. So what makes Jay's perspective especially meaningful for our death doula community is the bridge that he creates between the clinical medicine and mindful presence. He maintains a daily meditation practice and brings grounded, compassionate awareness to his work with patients and families. And I'm just going to let you guys take it away. Would you like us to hold our questions? Would you like us to put them in the chat? Let you guys
maybe hold the questions.
Yeah, you can give us what you got, and then we'll open it up.
Yeah. Okay.
All right.
So I was thinking about the integration of death doulas into the rest of the medical care team. And I thought, what might be possible if death doulas were seen by the medical community, not as an alternative to medical care, but as a supplement and an added layer of whole person care. And I think that's a real roadblock at the current time to integration into the general medical care team. I would say that this journey that the death doula community is going on to get themselves known to the medical team and get the medical team to understand what death doula services are and see them as a partner rather than as a threat really mirrors the journey that hospice and palliative medicine providers had to go through a few years ago, when palliative medicine was not very well understood by patients for certain and by much of the medical community. And I found that over my years of practicing as a hospice palliative medicine physician, a very big percentage of my time, aside from patient care, was education. And I had to educate other healthcare providers as to what palliative care was, how it fit in to the medical scheme, and how it was an adjunct to what they were doing. It was not palliative care medicine providers were not taking the patient's care away from the general medical team. And I see that the death doula community is kind of going through the same journey of trying to get themselves understood by the general medical providers and have them understand that death doulas are an adjunct and a partner, and not competitors. And so I relate to that challenge quite a bit because I went through it a lot in my own practice. So the things I'm looking at this from the point of view of a medical provider. I'm not a death doula, although I'm married to a death doula, and I hear a lot about, death doulas and their concerns and their skills and talents. But I'm looking at it from the point of a medical provider and thinking, what do I think would be necessary for the general medical providers to be comfortable with integrating death doulas? Uh, so I thought the things that I wanted to quickly discuss would be kind of the current status of integration of death doulas into the general hospice palliative medicine team. What are the impediments to full integration with the team? The kind of sad lack of awareness of what a death doula is and what support a death doula provides, not only by patients, sick people, their families, but also by a large percentage of the medical team. I know I have spoken to medical providers who really were not at all familiar with what a death doula was or how they fit in to the medical care plan, the treatment plan. So I think there's a lack of awareness in the general community and unfortunately in the medical community as well. The other concern that occurs to me is that medical teams, medical services, hospital administrators are all concerned with facts, and they want to know, how does this service improve patient satisfaction scores? Hospitals and hospices get rated by Medicare on patient satisfaction surveys. So hospices and hospitals' medical care teams are very attuned to the results of patient satisfaction scores. And to me, it seems like death doulas would be very helpful in their services to the patients. They're going to result in better patient satisfaction scores for certain. And there needs to be some way to measure that and transmit that to the stakeholders in the hospital and the hospice. The other data that those organizations are going to be interested in is their financial bottom line. Does a patient receiving doula services shorten hospital stay, reduce readmissions to the hospital, and perhaps allow earlier entry into hospice care? So I think those are all factors that the death doula community might want to look at and try to measure, and then use that as part of a presentation to a medical team or to a hospital or hospice, saying, well, we have studied our effectiveness, our impact on patient satisfaction, and here's what we found. There is another impediment to the integration of death doulas, which is the reimbursement. Hospitals, hospices, by and large, hospices don't have mechanisms for reimbursing death doulas. Medicare does not. And I thought I had read that some Medicaid services do reimburse death doulas, but that was misinformation. It was actually birth doulas that they reimburse, but Medicaid does not reimburse at this time for death doulas. So I thought, how do I think as someone who's not a death doula, but someone who certainly has worked with death doulas um, and sees the medical end of it, what do I think a strategy would be for trying to foster integration? And I think the grassroots is the best. I think one-on-one conversations with other healthcare providers, um, repeated conversations with education to educate them about what death doulas are, getting them comfortable with the concept, um, relieving them of some of their misperceptions about death doulas. I think frontline one-on-one conversations uh, would probably would work very well. Um, how could that be done? I think death doula organizations could set up lunch and learns with hospices, with home care agencies, long-term care institutions to just discuss what, on a one-to-one uh, basis, what death doulas are, what services they provide, how they benefit the patient, how they are an adjunct to the medical care team, not a competitor with the medical care team. Um, there may be opportunities to contact a medical training program and ask if you could provide a lunch and learn to medical students, to medical residents, to nursing students. I feel like getting in on the ground floor with professionals in training, I feel that sometimes they're more receptive to new ideas and they're less fixed in their practices and their ideas. And so sometimes I think getting in at the ground floor is a good technique. Um, there are some options for payments that I've read about, and I know payment is often a roadblock in providing doula services. Some hospices, or a lot of hospices, receive grants and private donations, and a conversation could be undertaken with a hospice as to whether they could use some of their private grant money or private donations to fund hospice services. Some patients have healthcare spending accounts, and they may be able to use some of the funds that they put aside into a healthcare spending account to fund doula services. Overall, I think the education of the medical team is really going to be the most important avenue to achieving integration with that medical team. They have to know what a death doula is. They have to not be afraid that a death doula is going to supplant them. They have to be convinced of the skills that death doulas have, and all the services that death doula provides. So I think it's the lack of knowledge of death doula stands in the way of medical teams accepting them and integrating them. So I think educational approaches are very important. I did read about a pilot program in the EU where there was an integration of death doulas into the hospice palliative medicine team, and and I will have to look that study up and get it to you, Shanti, where they did document in a small cohort of patients improved patient satisfaction, fewer readmissions to the hospital, and for people who were in the hospital, shorter hospital stays. So overall, I think the education probably has to be continuous, repeated, and sensitive to the concerns of the medical team. So that's kind of my perspective there. And I wonder what questions you might all have.
I can read from the chat, Jay. Thank you.
Yes, thank you.
Lisa explains that she's a massage therapist who works with hospice patients through local hospice, then trained as a doula. But one of the challenges she found is that there's no definition of service. Basically, doulas could wear any hat they chose: care manager, financial manager, personal assistant, companion, integrative therapist, and more. Don't know if this has changed, but it'd be helpful in helping hospice care team to understand how to implement the service.
Yeah, I think so too. I think the death doula has to be an understandable, has to have an understandable group of services that they provide. So I think developing like a scope of care document, I don't know if there is one yet, but developing like a document that describes the scope of care that could be presented and that's consistent from one conversation to another, kind of an elevator speech. Like if you had 3 minutes to describe what you do, what would you say? And entrepreneurs are often asked to develop an elevator speech. Like if you're in an elevator and says, "Hey, what are you doing today?" And you can like quickly and succinctly explain what you do. So I think a scope of care, scope of practice.
Yeah, and the thing we always talk about is what Jay said in the presentation, is that really could be focused a lot on what they consider a return on investment. Why would I invest in a death doula? By showing the patient satisfaction, and helping patients understand the medical treatment that they might be getting, palliative care and hospice treatment, helping them better understand that gives them gives them a better mark in terms of customer satisfaction. Talking to the medical professions and medical directors about the bottom line, which is customer satisfaction and, like Jay said, reduced hospital stays or
Rehospitalization.
right. That helps in the not only this is what I do, but this is the effect that it has. That's a concern for you, medical director or medical team.
Yeah, and people put in the chat that NEDA Alliance, NEDA, NEDA has a scope of practice that they've established.
That's wonderful.
And, so I think too that any opportunity that we get to find a connection within the medical system, if you have a client whose child, whose child was in the hospital and they have a relationship with the doctor, and if people ask, do you have a death doula, because I need more emotional support and the nurse is busy and the doctor's busy and social worker visits, but I need more. If the patients and their families are asking for it, it would increase their interest, or it would light up their ears, they'd hear it. And years ago, I reached out to hospice and the palliative care department here at UF Health in Gainesville, and tried planting that seed for them to know about me. But at the time, we didn't have a nonprofit, and I was not as seasoned in what I do. And so then eventually got a contact, a friend who is one of the physicians, and he actually just retired last week, pediatric oncologist. And it turned out that his patient died, and the same day he got that call, I received the call to be her doula. And we are presenting next Tuesday to the UF palliative care team about grief and our experience together with the physician. So the mother, the doctor, and I are going to give them a lunch and learn. And so it takes a while, but it takes having a vision that you can get in there with the hospitals and the doctors, and then finding a little connection that's going to lead you there, and just kind of planting that seed and nurturing it. Like I said, it took 3 years, but it did happen. And the meetings that they do on Zoom are also recorded, and then they're put into their internal system. So the first one I did in May was about what a death doulas do, and it was an hour, and that's already in the system. And now, the next one will also be more focusing on grief and how we can support people. And I'll just say in that particular case, I was able to advocate for the family when the sheriff's department was trying to tell them that that they needed to remove her body before the grandparents even got there. And I was standing in for the mom and insisting that that wasn't going to happen. So I see, yes, Jay.
One quick thing, one other avenue of discussion with the healthcare team is that the doula can save them time. The healthcare providers often feel like they don't have enough time to have the conversations that they want with the patient. The patient is yearning for more explanation, more time to figure out their goals. And the providers are too pressed to do that. And so the approach of saying, we can save you time, we can take some of these prolonged repeated conversations about goals of care. We can take that from you and do it for you and then report back to you.
Yeah, and then it's almost like we could be an interpreter between the medicine and the person, because sometimes the language might be confusing or just the energy. So we can actually get in there and explain what they meant and just be a extra layer. Anybody else?
Well, an interesting thing that happened to me was I was giving a presentation. I didn't realize that a physician was in the audience. I didn't know everyone. And I was saying, trying to figure out what, talking about the benefits that we have. And he raised his hand and he said, listen, when, working in the ER and somebody comes in and we don't know what to do, whether to resuscitate or not. And if the death doula has already worked with the family and prepared them for that decision, I am so glad that I don't have to make that decision, that it's already been done. And so just that kind of information that a death doula can provide to a physician at a time of emergency, and that's what we do, is prepare people for those type of situations. He says that really makes my job 100% better, because now I can do exactly what they want to do, as opposed to most of the time the family's asking me to make the decision, and that's not what I'm here for. I'm here to really provide the services that the patient wants. And I also saw a great question that maybe Jay can answer. Like, if we're going to be talking to a medical team, who would be best to talk to? The medical director, the doctor, the physician, the nurses, the administrator, the nurses. Most definitely. Why do you say that?
I just feel like the nurses are more tuned into the social, emotional, spiritual
Very true.
side of not across the board, and but I think they're a little more tied in to that part of someone's experience, and probably because in their work and in their training, they've been at the bedside much more than the physicians have.
And they recognize the value that we have by being there at the bedside. We have more time to be at the bedside than even the nurses can be. But they understand what the value is that we bring by having that close relationship with each one of the patients and being able to provide that information to the medical team. So I think you're a good answer. Nurses are a good place to start. But I say talk to everybody. But
yes, of course.
Yeah.
And I don't mean to insult the other people on the team who are the medical team who are not nurses, but just I think if you asked me to tell you what I think, I would say nurses.
And we have a hand up, Bernard. What would you like to say?
I pressed the wrong symbol. I pressed the thumbs up a few times.
Oh.
But I got the right one now. Hi.
Yes.
So I wanted to, possibly add a couple of observations based on what I consider pretty much a lifetime of experience. in alternative healthcare and alternative healthcare approaches. Like I was in a relationship years ago with a woman who was a naturopathic physician, not like a mail order kind. When she went to college, got a bachelor's degree, then went to Canadian College of Naturopathic Medicine for 4 years. I mean, a serious naturopath. And we lived in Florida, which I still do. And it's now 10 or 12 years later, and naturopaths are still not licensed in Florida, despite an active, association attempting, to make that happen. In the last couple of months, did a little experiment, and I mentioned to 3 or 4 different medical doctors that I know. And by the way, I always use the term end-of-life doula. I have personally found that it gets a more of a positive reaction rather than, oh, death doula. I mean, again, that's obviously, a person's preference, but that's just, again, my experience that end-of-life doula was a more gentle type of way of presenting the function of a doula. And I think it was 4 medical doctors that I mentioned it to, only one of them ever heard of an end-of-life doula. The other 3, they certainly know more about it now after me having conversations with them. And even the one who heard about it, he heard about it, wasn't completely sure. Then my estate is handled by a trust company. So I had a meeting with the vice president of the trust company and, one of their financial advisors. They never heard of an end of life or death doula. I mean, this is, pretty intense because they deal with the states with people that have passed on. They're managing, the affair. They never heard of it. So, like, my feeling is that, the medical profession is obviously, well, I mean, it's a bottom line, making money. Is somebody going to interfere with the medical doctors being able to charge certain fees, just like hospice has a fee for service, and is the doula going to interfere, with that function? So I'm all for, what you gentlemen are both talking about, of making it more known to members of the medical profession, however we could do that, whether it's, vis-a-vis nurses or even nurses' aides. I mean, I don't, however that is going to happen, but the resistance is still going to be there from the medical establishment, in my opinion only, this is all my opinion, for quite a long time. And my feeling is that one of the most important ways to make it recognized as a viable service to the medical profession is to increase the number of people in the general population who use the services of a doula at the end of life. And this could be told to medical doctors by the relatives of the surviving person, by the actual medical doctor of the person while they're in end of life care, et cetera, et cetera. And that's a way that I feel of helping us back in more and more to acceptance from the medical profession. Because if you're a doctor and your patients start asking you for a service, you're more inclined to give. Like years ago, before I was a businessman, I'm sorry to take so much time, you can cut me off. Before I was a businessman, I was a dentist. I was a mercury-free dentist. I was one of the first mercury-free dentists in America. 1981 is when I stopped putting in mercury amalgam fillings. And the resistance from the general dental establishment was intense. I mean, I've been putting these fillings in for 40 years. No one ever died in my dental practice, that kind of stuff. And, even now, more and more, it's being recognized that it's a poison, it's a neurotoxin, etc. But that's because more and more patients began to ask their practitioners, did they offer such a service? Did they ever hear about it? Blah, blah. So and I want to just add one thing and then I'll cut out. I also feel that possible presentations made by end-of-life doulas to independent care facilities, to assisted care facilities by people who are on the way to possibly and potentially utilizing the services of a doula would be maybe another effective way of getting out there and getting known. Well, that's my two
Thank
cents.
you.
That's my two
Thank you
cents I just
so
put in.
much. It was
You're
20
welcome.
cents worth, Bernard.
Okay,
Thank you
you're
so
welcome.
much.
Thank you. You're
Yes,
welcome.
thank you. And yeah, we usually do say end of life, by the way, but this time we just thought we'd go a little radical and try it, but it's more accurate to say end of life because we're like way a continuum. We're not just at the death. So yeah, I take that very kindly. Thank you. And we're going to go to Kevin, and then we're going to actually have our third speaker, Nathan, come on after Kevin.
Yeah, thanks, Shanti. And I'll be as quick as I can here. Thank you,
Oh, no.
Shanti, for inviting me. Dr. Lippman, I agree with everything that you've said. And I'm so happy to meet you this way. I'm a hospice and palliative care doc in Cleveland, just retired after 36 years. There's so much similarity here. And this vision that we need to be doing a better job with not only end of life care, but upstream. And kind of my vision now is to find ways to do all of the things that we're talking about here and find ways to incorporate doulas not only into hospice, but upstream in palliative care, into nursing facilities, the whole gamut. And I really think part of it needs to be based upon what the last speaker said, kind of a grassroots movement. It takes a village. I don't know if it's going to come from the top down. So all of that being said, I would like everyone to know, and Dr. Lippman, I'd like to talk to you at a later time about this next April of 27, at the end of the month. Our medical school, Northeast Ohio Medical University, is sponsoring a conference about this topic. We're inviting the medical folks and the doula folks and everybody else to the same table to bring things that they know have worked in their communities, to sit and learn together, to share the space, come up with common ideas on how to make this different, to reimagine end-of-life care. A couple of the doulas that I'm working with are on this meeting. And so Shanti, I could just send you information as we get it. If anyone is interested to carry on this conversation kind of in a bigger setting and meet some other people, we'd be glad to have you. So thank you for the few moments here. This is good stuff.
Yeah, I wouldn't want you to feel rushed. Is that going to be, I forgot if you said if it's going to be a hybrid meeting or an in-person meeting, or if you know.
Yeah, right now we're focusing on in person, 2.5 days. It's going to incorporate the humanities. It's going to be south of Cleveland at our medical school, which has a huge meeting space. So we're putting it all together now.
Tell us again what that school is.
Northeast Ohio Medical University. The acronym is NEOMED.
All right. That's wonderful. We met each other because I said, "Oh, a doctor who's reaching out to doulas. Let me jump in there." And thank you so much. And then, Kevin, you're giving a talk tomorrow?
Yes, on HAPSI, actually.
Okay. Anything anyone has to offer, please put it in the chat so people would know if there's a link or a notice of where to go to involve in this. Feel like this is a beginning for us. So wow, this is great. Again, it's the biggest Zoom meeting we've had, 45 people here. Thank you so much. And now I'm going to introduce Nathan Vargovcik. Okay, good enough. An end-of-life doula at Birchwood Senior Living in Minneapolis. He's employed as a doula. Nathan began his work in 2022 through hospice volunteering, and he went on to complete his INELDA training, that's the International End-of-Life Doula Association, later supporting the residents alongside experienced doulas in a nursing home setting. Today, he serves as a staff doula within a healthcare environment, while also working with private clients, bringing a deeply compassionate and grounded presence to end-of-life care. So we would love to hear from you, Nathan, about how you got where you are and your work and what it's like.
Thank you. Appreciate it. Grateful to be here and to share my experience. Yeah, I think I just want to make it as much of a conversation as possible and just tell you how I got to where I am at, and then just open it up for conversation. And also talk a bit about the story of how it came to be that there are employed doulas in some skilled nursing facilities here in the Minneapolis area. So yeah, like Shanti said, I started in 2022 with hospice volunteering, kind of just based on my own struggles with mortality. I was having some illness, some sickness issues, some health issues, and was always afraid of dying. And because of that, I started to read some books about dying, and that just kind of sparked my interest. And initially, I had the thought that I wanted to become a hospice chaplain. And I might still, I don't know, but that was my first thought. And then it just kind of led me down this path of like curiosity, and just like I kept following it. And eventually, that was about 6 years ago. And then eventually I started volunteering. At first, it was hard to do because of COVID, and I wasn't able to do it in person for a while. But then in 2022, I was able to start doing it in person, and I got my I did an ELDA training at the same time. So a little over 4 years ago, I did that. And then 2.5 years ago, okay, so 3 years ago, after about a year of volunteering, I connected with a woman here named Jane, who is she started the Minnesota Death Collaborative, and she is one of the staff doulas, and she was the very first employed doula here in Minneapolis, and through a nursing home. So I met her, and they still have it. They have two staff doulas at this nursing home, and they have a whole bunch of volunteer doulas. So there's like 15 or something like that now, I think. But so I started volunteering because I had been hospice volunteering for a while, and I just thought like I'll volunteer with these people. And so I started doing that, and then about 6 months into that, a position opened up for a doula at a different facility, and Jane urged me to take that position. So I applied for it and interviewed for it and got the job about 2.5 years ago. And yeah, at first it was I was working 20 hours a week on top of my full-time job, and I did that for quite a while, and it was, it got to be too much. So unfortunately, I've had to kind of reduce my hours because it doesn't there isn't really like a full-time option that's viable for me, to do that at this facility. So I have to do part-time right now. But I keep doing it because I want to stay in the work. And but yeah, so and the way that it came to be, so there's 5 employed doulas between 3 skilled nursing facilities right now, and 2 where I work, 2 at a different facility, and then 1 at another one. And we're talking about hiring more in assisted living, because attached to the skilled nursing facilities are the assisted living facilities, and they're talking about hiring doulas there too. So that's an opportunity that may be coming up soon. But the way that it came to be was so the Minnesota Death Collaborative, they do these monthly community calls, and they just kind of open it up to the community to talk about death, whatever comes up, death doulas, whatever it is, just open it up to talk about death. And during this call, someone asked Jane, who was hosting it, because she was one of the founders of the Death Collaborative, if they knew anyone who was hired as a doula. And no one knew anyone that was hired as a doula. But then shortly after that, this person reached out to my friend Jane. And so basically it's just kind of a classic, like someone knew someone who knew someone, So this person, her name is Nancy, and actually I did my INELDA training with her. She was very tight with someone who's like a high up board member of the nursing homes we work at. So because of their relationship and this person's belief in death doulas and their importance, I guess sort of I don't know about convinced. I don't know exactly how it transpired, but because of that connection, eventually this person who was good friends with chairman of the board got the chairman of the board to decide to hire doulas. So that happened in January of 2021, and Jane was the first one. And then, yeah, it just kind of, for some reason, the board appreciates us still and wants us still. Well, I know why we're valuable, but I think it's, a lot of the things that other people have mentioned, like the financial viability of it, I don't know about that. But I just know that they want us there, and enough that they're not only, well, they're expanding they're trying to expand it, rather than kind of cut it back. So like with her talking about adding it to assisted living facilities, and basically, and also Jane right now, stepped away from being a staff doula and is now kind of, she's basically doing pilots at different facilities to kind of see the viability of having doulas at other facilities right now. So, but she's doing that through the organization we work for. So, yeah, and then, yeah, so that's what's going on right now here. And I'm, yeah, grateful to have the opportunity to do the work as an employee doula for the past 2.5 years. Yeah, it's been interesting for sure. Yeah, it's been a wild ride, but yeah. Yeah, so if anyone has any questions or comments or anything, I think, unless there's anything else anyone would want me to talk about.
Nathan, how did your facility define your scope of work?
They don't really, which is kind of a good thing and a bad thing in a way, because I think they're in trying to like scale it. It's like we don't really know how, because it's like so different in each facility, because they have their own cultures, and it really right now it's been very loose, but we do have maybe about a year and a half ago, we got a doula liaison who is sort of our go-between between us and the board. And so she's like reporting to the board about us, and they're trying to scale it. So they're trying to have us have more defined cross site uniformity, I guess you'd say. So we're working on that, but at this point it's very loose, I would say. Yeah. We don't really have anyone to answer to. It's interesting, yeah.
They trust you then. I mean, they really see your value, and
yeah,
it's working.
Yes.
That's great.
Yeah.
Yeah, Jay and Bob have their hand up there.
Yeah, I certainly have a question because you piqued my curiosity. What is a day in a life like for you as a staff doula? What kind of services do they have you providing? What are the needed services, that type of thing?
Yeah, again, it's kind of like it's up to our own discretion. And I would say, but the thing that I would say that I feel the most important thing that we do is advocacy, because there's just inevitably disconnect between care teams, like our nurses on staff are not trained in hospice, and they don't they're not bad nurses or anything like that. They're not bad people, of course. It's just like they're not trained in that way. And so they often miss signs, about a resident's decline or their pain or their whatever it may be, or that they're beyond the point of eating and drinking, and they'll miss those things. And so I think I just try to, what I do, and I think what the other doulas do too, is a lot of advocacy about that, so we're in a lot of contact. So the way it works is that hospice is outsourced basically, right? So like a person is in the nursing home, they're on hospice, they can choose a hospice organization, and then that hospice comes to visit them in the nursing home. So we're in communication with the hospice team a lot because we're noticing these changes, and a lot of it is like just reporting what we're seeing and letting them know that a person is uncomfortable, or that that because it's not, because things don't get ordered, you know, that a lot of times, like with PR, there's PRNs and things don't get ordered. There will be big gaps in time when a person receives their meds, you know, that, and then you can tell that they're in pain. So a lot of that, and just like supporting family and letting them know that they can advocate too, because I think a lot of people, of course, they're scared, you know, and they're facing the scariest thing of their lives usually, and it's just supporting the family and being present, and letting them know, like, um, yeah, like if someone seems uncomfortable, like don't just you can inquire, you can ask about that, you can advocate for your loved one. Because I think a lot of people don't know that they implicitly trust healthcare, you know, and I mean we all do the best we can, but
Well, and like if I could say, chime in for a second, I think one of the things you're saying is I think a doula may be more attuned to the patient's symptoms than a non-hospice nurse. And when I was caring for people receiving hospice services in a nursing home, if the nurse did not have hospice training, they often were not savvy about picking up the nonverbal signs of pain. And somebody would have an as needed pain medicine ordered, but not receive it because they didn't have the wherewithal to either push the button and say, or having pain, or didn't have the cognitive capacity to say, I'm having pain. And most people who are at end of life lose the ability to communicate that they're having pain, and they rely on the nurses seeing the nonverbal signs of pain, twitching, grimacing,
mhm,
muscle tension, irritability.
mhm,
So I
yeah,
think it's great that the doula at the bedside could help bring the nurse's attention to that, because there were times when I'd have someone who had as needed medicines ordered and they never got it because the
yeah,
nurses didn't recognize they needed it. So I ended up having to just order it on a schedule
yeah, exactly, yeah, yeah,
and say with a, say, give this medicine every 4 hours. You can hold it if the person's sleeping.
yeah,
The thing that I heard you say too was you report what you see.
hmm,
And you are another pair of eyes that's seeing things differently than the medical staff or the family.
hmm,
I think that's a big value of what end of life doulas provide is reporting what you see. Because
yeah,
we're attuned to things that are different than what most people are thinking about. And then the other thing about advocacy is not only advocacy for ourselves, but advocacy for the clients. They don't have advocacy for themselves because they give over the power many times to the medical staff
yeah.
when they don't realize the power that they do have and the rights that they do have. And we can provide that kind of education and support.
Totally, yeah, yeah. Because yeah, a lot of times people don't. It could be their first death, you know, and they don't exactly know the signs, you know, of their what is going on with their loved one, and that they can maybe improve those conditions if they speak up, you know. But that's what we're there for too. And then, oops, go ahead.
I just see that we have another question, another hand up. Maybe it's hard to
Right, that's what I was going to say. We'll let Sinead say what she'd like to say.
Thank you. Good evening, everybody. I was going to ask a question about hostility from medical practitioners towards doulas. And Ethan, if you've encountered anything like this, I have at the hospice where I was volunteering. The supervising doctor was extremely hostile to me being there. And one of her points, or her arguments, I would say, was about doctor-patient confidentiality, and that she did not want me having conversations with the dying person or their family members about the dying person's condition. Of course, being an INELDA-trained doula, I have some idea of the dying process. I would say I'm certainly not a medical practitioner, and it's a non-medical role, and I'm very aware of my lane. So, two questions. Have you had any, whether it was with other family members or other medical practitioners, have you had any conflict issues? How did you resolve them? And the other question was, for the medical practitioners in the group is, what is doctor-patient confidentiality based on? Is it a legal document? Did this argument have any real merit to it? Or was she just pulling something out of her derriere?
Well, my observation would be, if the patient has agreed, has either engaged your services or agreed to your services, then they've given you permission to hear their protected health information. And you really, whether that physician likes the idea or not, you've become part of their medical team or their treatment team. And the patient's acknowledge, the patient's permission to you to provide services for them allows you to have protected health information as far as is necessary to perform your services.
I'm glad you said the word team, because she very specifically said I was not to be introduced to any admissions, any residents that were brought into the hospice or their family members as a part of the team. She was very specific about that, even though, so after the incident, I continued to sit with the client because I was engaged by him. And I had to sign in as a friend, not as a volunteer.
Well, and I think that kind of relates to what I've observed about some medical providers being very hidebound, old ideas, old entrenched ideas, reluctance to embrace new ideas, lack of flexibility or imagination, if you ask me. And I think that presents a challenge for the end-of-life doula community.
Very much so. I was actually treated quite differently after that incident, and the nurses were instructed not to speak to me.
So here in Florida, I know the different hospices have different policies. If you have death doula skills, if you have been trained as a doula and you're a volunteer, they want you to just be a volunteer. There's some of them that say you're just sitting with the person or whatever, and they're very limited in their scope or their understanding of what we are. But if you're known to be a doula and it's all about the relationship. So I think sometimes we just have to realize that we're in their space, and we may just want to kind of back off a little bit so that there will be, just a little politeness and say, "Oh, I didn't know," because otherwise that we're going to be known as the agitator or there's a balance, but I don't know.
I did actually stick it out until the client passed away, and then I went to a different hospice where I'm more warmly received. So I'm committed to a different hospice entirely until that supervising doctor moves on.
And so you've challenged and you've had that, and it's all good, and you found a place.
Yeah, I did. I did actually not just walk away. I did speak to the administration about this, and the administration was quite upset. The administration recognized the value of my role, and the administration was the one who said, "She cannot stop you from coming as a friend." So she encouraged me. She's like, "I know how you feel," and it really disrupted that energy that I tried to bring to the role, which is unfortunate, but that was a growth moment for me. It was a challenge for me to really be able to center and still sit. So I was just wondering if anybody else had any of those conflicts and how they resolve them.
I haven't had that. Oh, I'm sorry.
Go ahead. No, you go ahead.
Because I haven't had it to that extent. But the way that I resolve it, or would possibly resolve it that way, is to remember that I'm there as I'm there as not only as a friend, but as a behalf of the client. I wasn't asked to be there as part of the team. That's fine. I still can provide a lot of service to that client by being there in the room and being there, and I have a place there because they've asked me to be there. And I could still perform my role as best as I could, advocating for them, but not as part of the team, as the medical team, because my job is to advocate for my client. And the best way to do it in that situation, I could still be very effective, even though I'm not part of the medical team.
That's why this raising awareness is so important with
Exactly.
the medical community, is to
Yeah.
just have a stronger foundation for our role.
Mhm.
So an hour is not enough, right?
Never.
I don't know, maybe we just need to do an extra meeting sometime. We'll put it out to everyone. I know Nathan was about to say something and I do want to let him, but I also want to say, Christine, were you saying you'll send this chat out? So put anything you want to put in the chat, please do, because the chat is going to go out by email. Is that correct, Christine?
I'll clean it up so that we can see the questions
So
and the
we can-
contacts and the resources.
Great. And then Nathan, what you got for us?
I was just going to answer your question about hostility from medical teams, right? That's what you asked. I wouldn't say hostility, but definitely skepticism. And I think for me, the way that I handled that was just I had to find ways to talk to nurses and talk to medical teams, like without telling them what to do, but more just like maybe hinting at something, like this person seems uncomfortable. Do you know if there's anything scheduled for them that they may be getting sometime soon? Just trying to find like ways of, yeah, just like hinting at it rather than just saying it outright, like, and I think for me too, for a long time, I just had to kind of just put my head down and like work next to everyone, and not have an ego about it, not argue with people, not try to prove a point or anything, but just like put my head down and work and just like show them that I'm here to just serve this resident. I'm not trying to do your job. I'm not trying to take away your job. I'm not trying to, do anything than just serve this resident. And I think that in doing that, slowly it earned their respect, so that I can at least work with them. And um, I think people still have like their attitudes, about it. Some of them do, and that's okay. But that's just people, that's just like anywhere. Yeah. So I hope that's helpful.
Very much so. I really appreciate that, and appreciate all the input that's been brought here today. So much to think about and to go out and build those bridges, make those connections, ask those people, tell them, give talks, let's get out there, because I feel an exponential movement going on here. I mean, it's really picking up. So where people don't know about death doulas or end-of-life doulas, they will soon. So again, if you want to put, Kevin, did you put something in about the conference there where people could reach you or your website or something? You're muted, but thank you. Yeah. So that'll go out and we'll be looking forward to that. Kevin has a very nice website, by the way, too. So, well, goodness, this has been amazing. I want to thank you, Jay and Bob and Nathan and everyone who shared their experiences and wisdom and listening and all of that. We're not going to have these Zooms in the summer. I believe we're going to skip July and August. I think so. But we will start back up in September, and you guys are on our list. Appreciate everyone.
Yeah. I just want to say too, I put my info in the chat if anyone wants to reach out. I'm always open to talking about this.
I think it'd be great to see a number of employed doulas and get you guys, get something together and invite us.
Yeah.
We'll help spread the word.
Mm-hmm.
Any closing thoughts from our speakers?
This has been great for us to be here. Great to see the support. Great conversation. Interested to get in touch with a couple of people who have spoken up. Maybe we'll be heading out to Ohio. Jay just said maybe it's a good idea to be there. We'll see what happens.
Oh, yeah,
Yeah.
definitely.
Yeah. And
Pioneering it, right?
yeah,
Great.
I definitely want to get
Thanks.
buddies with Nathan to find out more about that experience and that road. So thank you very much.
Yeah, thank you too. Thank all of you. Yeah.
Make sure you put your email in there. Thank you so much, and we'll see everyone soon.
Everybody.
Appreciate you all.
You too. Thanks.